The TV wasn't.
It's a very secure meeting here. It's like, this is a highly exclusive. We are all.
So I'm recording and it's transcribing. So when I open the chat, every word we're saying was typing in the chat, which I've never seen before.
Simone, can you hear us?
I can hear you. Can you hear me?
Oh, holy moly.
Way too loud.
No,
we're just super excited that it's working. So
geez Louise, it
it's like
worked.
all it takes to get us to like get super excited.
I'm sorry I'm not there. I was exposed to COVID, so I didn't want to expose anyone else. Figured it was better to be on the screen.
Got a couple of us off screen, Simone, just so you know.
So I am going to just share my screen real fast. And in full transparency, I did not want to do very much talking at all because I wanted to hear from all of you. And again, I know that we're a little bit under time or behind. So, hold on 1 second here.
And I'm gonna take notes about themes and comments. I will not be attributing it to anyone, it'll be general. So just so you know, that's.
So again, I think everybody knows me, but I'm Steve DeVoe. I'm the Director of Quality and Accountability at DMH. And I was a co-facilitator of this work group with Ina Bacchus before she left. And since then, there wasn't really enough time to go through the rigmarole of trying to identify another co-facilitator and get them up to speed with everything. So it's like, we have such expertise and experience in this group already. And then with the council as a whole. So we'll just move forward. And I'm lucky enough to have assistance from my awesome colleague, Cheryl Wilcox, who's the Director of Mental Health Collaborations. So, so this is the summary recommendations that, after a lot of different discussions from a lot of different stakeholders and thinking about kind of where we're all respectively at. And not to say that, that's any one specific place, because a lot of people are obviously coming into this space with a lot of different experience, both personal and professional. So I think that, that was one of these needles that we were trying to thread as far as, when we're making kind of some concrete recommendations to at least move this work forward, what are some kind of 2 or 3 major things we can hang our hats on, at least to, again, like I said, at least take a few steps forward in this work, knowing that it's going to be complex. It's not necessarily going to be easy. And as I said, people are coming into this space from a lot of different places. So there's a lot of different thoughts and feelings, which are all very valid. So, so these were kind of the 2 summary recommendations that we had landed on. And so I'm just curious again, and I know this document has been circulated before, but this is really where, again, I wanted to hear from folks to be able to ask questions, make comments, to really try to, I would say, tighten this work. And I mean, tighten it in a very concrete, actionable way. Because in my mind, it's super easy to talk about things at a very high level and kind of an esoteric level, for the lack of a better term, but that's not necessarily going to give us, or, like, for example, DMH or the state or AHS, the concrete steps we need to kind of, again, move things forward, be able to come back in 6 months, 12 months, 18 months. Did we make any progress? And be able to actually have that level of concreteness, because personally speaking, I think that's what's going to be needed to kind of keep moving this forward. So
can somebody just quickly read left my glasses?
Oh, yeah.
And I read them a month ago.
No, thank you for saying that. I can also actually.
What are the 2?
Yeah, so the first one was to conduct a formal needs assessment to assess variety and the use of performance measures across healthcare organizations state government entities, and health insurance payers. So that was the first one.
Mhm.
The second one was to pilot integration models in different healthcare settings, and integration models being a specific thing. There's a number of different things in the research literature, but to pilot, one or two of those models in different healthcare settings to study the impact on healthcare delivery funding, and we said any improvement on established performance measures, but even before we would get to improvement and, based off of today's discussion, making sure that we're actually collecting data.
Yeah.
And, having some level of measurement, because one of the things, I've been struggling with in the CCBHC realm is that, there's vast pockets of data we're missing on specific groups. And, if we don't even have just general baseline data, we can't even move to improvement. So it's like, we just need to be able, so that might be my own recommendation of, language change,
So, yeah, so that is what I remembered, and I really did want to comment on the first one, which the way it was articulated and so forth, was a real disappointment to me, because I think it articulates part of what this council was supposed to actually do. And so to say this is what should be done.
Right.
And I'm saying that specifically in terms of insurance parity, where we have such an utter failure currently, both in terms of workforce. But I think the example that I just gave the two commissioners, or deputy commissioner and commissioner, because I thought I want to make sure I'm right about the history here, but I think it was roughly 15 years or so ago that the healthcare system, the hospital driven and so forth, started recognizing the overuse of emergency rooms for, you got pink eye, got whatever. So they created urgent care centers for when you can't reach your primary care doctor, but you don't really need an emergency room. And the healthcare system, systemically driven by hospitals, created those and have them reimbursed and are part of that system. So in the past year, the state, through the Department of Mental Health, has issued RFPs for the funding of urgent care centers for mental health. What? Why would the healthcare system in the same way not be funding it? And the answer is because the business model wouldn't work, because we don't fund yet in a parity and equitable way. And that's just like one kind of really blatant, clear-cut example of how parity has so far to go systemically as an obstacle to integration. And you could go and say, same thing with inpatient care. The state just issued an RFP to create an inpatient unit. Would we have an RFP for a cardiac unit at a hospital that the state would fund? What a bizarre concept, but it's not bizarre to us because we're so used to the lack of parity in mental health services. So.
I really appreciate that comment. I've been thinking a lot about the RFP process in mental health lately. And I think you just articulated it so well when you asked, would we do that for a cardiac unit? We wouldn't even think about it. So I just want to say I appreciate that comment.
And I know DFR is aware that, when you look at hospital reimbursements, as we hear all the time from hospitals, Medicaid underpays for everything in hospitals and it has to be made up for in the private system. The only area that's not true, Medicaid overpays for mental health and private insurers underpay. So, what happened to our parity law? And where is when Allison said, what do we need? What do we need to address? And what were the commitments by the non-state players where's the insurance commitment for parity in reimbursement to make mental health an integrated component? To me, that's a huge question. I didn't see the commitment from hospitals, from insurers to do that. Hospitals, I didn't hear a commitment from them either, but their answer would be, but we don't get the money to do it. There's more to it than that, but anyway.
I was kind of looking at number 2 and thinking about all the different creative solutions we've talked about in the last couple of years, and thinking maybe it would make sense to even start with an inventory of what's out there. Because there's a lot. Yeah, and then also to apply a standard method for evaluating that. I'd probably go like the cost benefit route. That's kind of one of my preferences. But we're gonna do a cost benefit. Here's the kind of costs we're gonna look at. Here's the benefits we're gonna look at. We're gonna measure kind of the same way across all the different existing pilots, so we can get to a standard, because otherwise it just becomes once it's really hard.
Right.
It's really good. There was also UVM actually was involved in a major national study on, is this the best model to do and cost benefit wise? So knowing what's being done has been done.
Benefits too, right? There's societal benefits. There's the individual.
Yeah, I think that methodology piece for me definitely resonates because it's got to be done in a very rigorous way.
Mhm.
Because otherwise, it's just piecemealing things together, and then we're inevitably in the space where we're just kind of throwing spaghetti at the wall, and then it's like, well, does this work? I don't know.
So compare to too, right?
Right.
Like this one we did it that way, and that
Right.
one we did it this way.
And I think when we had, landed on number 2 with the integration models, we were really trying to think about, some of the models we've studied as a council, some of the models we've had presented on. But again, knowing how best to kind of right-size those models so we can apply them in a clinical setting in real time. But I'd be remiss to say, especially given my last job, the burden that can place on staff in that setting. Because in addition to, you're doing your normal day job, there's going to be this person there, who's going to be studying the rigor with which you're applying this methodology, and you got to be measuring this and that. So how best to kind of, again, make sure that we're not lowering, the quality of existing care in the name of doing something else. But there's certain ways to do it, for sure. Others. I know you're just coming here for the first time, but.
Yeah, I'm the first and last.
This is, this is, I think, really something, again, and I was gonna allow you a few minutes to maybe talk about what DFR is looking to undertake, if you wanted to talk about that.
Sure.
But yeah, if you want to, go ahead.
Sure. I apologize, I'm not on the camera, but that's okay.
This is the world that. This is the world within which we live.
So my name is Anna, and I'm from the Department of Financial Regulation, and most of the time I'm deep in looking at contracts to make sure they have the proper benefits. So I was allowed out of my hobbit hole to come to a real person meeting where everybody has legs. So thanks for having me. At DFR, we have a charge to update a list of services that are considered primary care for mental health and substance use disorder. And so we're just starting to build a focus group. No, I'm sorry, not a focus group, a stakeholder group. And that we especially want the clinicians. This was like the gold mine of stakeholders here, so I couldn't pass up the opportunity. I have just an informational piece, and we'll be emailing it out after the meeting to talk about, what are we doing? What is the current list of services that are included as primary? And the criteria for choosing more or revising the list and our timeline for undertaking the project, because it will, we're looking at revising our list this fall, and then we have to take it through a rulemaking process, and then we'll have an effective date to give people a chance. So it's, beginning stages, and my hope is that, we can get to rulemaking by the spring, for sure. We have some consultants that are helping us run the stakeholder process, because we also have our day jobs. And then I could just talk a little bit about mental health parity. And Vermont as a leader certainly has 4089B. And then we also have the federal MHIC legislation, which is measuring mental health parity in a kind of a new framework, I'll just say. And with that new framework has also come, some more interest in funding the work. It's really difficult work, and we're, on a tight staff, period. So it involves looking at a lot of, claims. If you want to really check, we have to do the check on the back end. So our approach is, there's a new self-assessment tool, which the idea was to have insurers self-surface their non-compliance. So I'll just say that we'll just maybe use that as a part of the tools that we need to do, but we do need to do a back-end check. And one of the things we're really looking at is denials.
It's time to circulate.
So please join our stakeholder group
If
and.
this group would go to workforce development in the main room, that would be helpful.
Thank you, Kathy.
And my next question would say that's.
I was gonna say, I think everybody has my contact info, but
Yes.
I was gonna say, I think everybody has my contact info, but again, if anything else comes up, please email me. And we can, again, make sure that it gets put into the notes. Just want to thank everybody for their participation. Much appreciated. Thank you.
So we're all supposed to switch, right?
Yes. I mean, unless you want to stay, Simone.
Yeah, I'm good.
I'm trying to think of
switch.
how to word it, but for me, what's been clear and like returning to community and mental health is the difference between mental health and substance use.
Yes.
Different regulations, different payment structure, different thing, and it seems to be secondary.
And how's this fit into the CCB?
Well, it sure does. It's a primary focus, right? Like it's all of our goals attached, all about trying to measure and figure out how we're gonna pay and heavy focus on substance use.
Yeah.
Yeah.
The soul.
Oh.
Yes.
Could you look and see if what?
I was noting that you were getting notes in there on real time, but.
Yeah, so I wanted to make sure what I wrote was accurate, what you just said. So.
Oh,
But
I'm
it's not on the
sorry.
screen, so if you look at my screen, my computer screen.
Oh, sure.
Because it's. It's right down.
I also not put breathing on you.
I just want to make sure I got it.
You got it. Sam's last point, but.
Thank you so much.
So Dr. Hank,
So,
how are you?
living the dream.
Good to see you.
Living the dream.
So for this work group, we were just reviewing kind of the two summary recommendations and giving folks like yourselves a chance to ask questions, make comments, shoot holes in any of the language to try to tighten it up. But as I said to the last group, at least my personal bias is that I want to make I want to make these actionable, concrete steps. Because I think that that's super important, but obviously not to lose the theme of, you know, relationships that we built in this group. And how we, you know, keep people at the center of all of this work, and especially when it comes to the funding and performance measures piece, because that can get very technical very fast. So. But yeah, if you have any, so again, the first one was to conduct a formal needs assessment to assess variety and the use of performance measures across healthcare organizations, state government entities, and health insurance payers. And then the second one was to pilot integration models in different healthcare settings to study the impact on healthcare delivery funding and improvement on established performance measures.
So one quick thing, in terms of the needs assessment, if you're gonna do like some sort of like scraping of data to see what's a little is actually the need, you're missing two key codes on the DFR list. One is the crisis codes and one are the collaborative. So that's an easy add, just put a couple of codes in.
And what was the second one again? The collaborative
Care management. So like, so in here, the Haynes model.
Yeah.
Like one of the things they have a couple. Over time, try account for like the care manager and the psychiatry consultant's time.
Yeah.
So they are theoretically being used to, it's going to help you sort of inform parity and utilization questions.
Are those codes, maybe not so much the crisis codes, but I'm thinking about when UVM Medical Center came and presented, I think it was over a year ago.
Yep.
But again, I take it those are codes that are being utilized because they're from the Ames model from the University of Washington.
So I would just add it to your list. Just
No, that's great.
round it out.
And you said those are missing.
They're not in this DFR current code list.
And that was,
That's me.
Well,
That's my problem.
no. And I wasn't gonna like,
Out somebody.
well, and I think the one, because you and I didn't necessarily connect directly. This is Anna from
Hey,
Department of Financial Regulation. I'll let you introduce yourself.
Joe's copying notes. I'm a psychologist. That was part of like
When, so I had received your, I don't know if it was from you, but it was from Sebastian or somebody at DFR.
It was probably,
And it was, you know, like, can we have at least a working list of codes? And I had given them to my supervisor, who's Deputy Commissioner Cron.
Yeah.
And I just thought, well, this is just an initial list to at least try to get the work started.
are you talking about the crisis codes?
I'm talking about any of the codes,
Oh, okay.
all the procedure codes.
testing is not.
So that was my thought, which, you know, this is a spoiler alert for our later discussion of
Yeah,
like how best to kind of go about doing a comprehensive look at all the different codes, and especially codes that intersect with like the, you know, anything to do with collaborative care management.
Yeah,
And I'm glad you mentioned the Ames model, because I know that they just had an explicit list, and this model.
that's great.
Yeah, it's out of the University of Washington, and essentially they just have all their playbooks online. Like, you're interested in doing this? Here's the whole stack of things. But they have billing, like, you know, billing manuals and, you know, all of that stuff, so.
Which is great, because it's great for us to bring into a stakeholder process and establish this.
Right.
You know, from some kind of research and
Right.
et cetera. It makes it a little less controversial.
Yeah,
And we were wondering about the crisis codes, I'll tell you, like, because there may be some revisions that are needed to the whole thing when you think about crisis codes, because it also talks about the situs of the care being provided
Right.
as one of the criteria. And right now, a lot of, I think, crisis services that are provided in the community wouldn't.
Yeah.
Well, right,
What's
so
getting captured?
the DAs do bill some sort of crisis code. So I work
Yeah.
in like an outpatient peds clinic.
Yep.
So like we're using them. And we could probably, in terms of like parity and like developing cradle to grave parity.
Are you in a pediatric primary care?
I am. So I would throw it
Great,
in.
well, I mean, not to put more work on you, but like, we don't need you to come to meetings if you can just tell me what you want.
I do that.
Yeah.
Well, and the other big one, of course, because like everybody's hearing about it. Stress. Stuff is like testing codes. So psychological testing, neuropsych testing, developmental testing. So,
Okay,
yeah,
we want that, I mean.
yes, I think so.
Is there just a whole like subheading of psychometric?
Yeah. But I can try to just.
I mean, we can,
Yeah.
whatever's more convenient for you, because it's not just on you.
Those are the three big headings for people who for everything from autism and intellectual disability to dementia and so like you get all those codes in. There's a billion of them now because like something called having a text, involved me doing it myself, like, but that all sort of cradle to grave capture utilization service. Make sure.
Is there, because I'm sure, I mean, in your off time, you're not memorizing procedure codes. Is there a person at either in your office or through like medical center or health network that you would recommend as far as like touching base with that's like medical coding?
We do have a billing.
Okay.
Totally blank,
No, that's okay.
but there is that resource.
Okay. And even if it was somebody even in your clinic, that's at least a start. But I know probably everything gets moved over.
It's a giant wheel. We just send it.
Yeah.
Some person feels honest. You might be wrong. I don't understand.
I just work in the Department of Medicine, so
Yeah. Just try to do a good job.
everything just gets sent off.
Make it work.
Now, that is super helpful.
I,
Yeah, no.
so, you know, I think a lot of the like program reviews that I've seen or like reviews of the Ames model and stuff are looking at things which, from my perspective, are relatively meaningless. Like a drop in the PHQ screening score for depression symptoms tells me nothing about whether or not I'm actually doing better, and like working, missing less time, like it. But so thinking about like when we're doing any sort of performance eval, like finding an explicit way to capture function. I think it goes back to what, you know, I was saying, like how on your terms are you thriving? There are some really nice, brief, psychometrically sound kind of quality of life measures that we could build in, so we're not just looking at like some symptom we heard in, but getting to like what matters to people and what matters to stuff. Score, it's like
Right.
I go to work,
Right.
show up. So, yeah. It's not just number of consults, it's not just drop in screening scales. It's finding a way to really explicitly say and operationalize like engagement, functioning, right? Whatever. It's not too qualitative or too burdensome because it's
Right.
so those measures are out there, they exist.
And there's a couple tools that it sounds like you're aware of.
Yeah, they're free. Like so, like there's a form set called there's a heading promise. That's patient reported outcome measurement system. It's just, you know, I think NIH before a billion years ago.
Wait, repeat that again.
Capitals PR. Oh yeah, that's it.
Oh, that's
It's
it.
a gigantic form set that has, you know, psychometrically useful, responsive to change measures for everything. Health stuff to I got knee surgery. Actually,
Right.
um,
And it's like a self-assessment tool almost.
totally, Yeah,
like for somebody to be able to say something about themselves.
exactly. And there's within that form set
Mhm.
that build off some other sort of functioning and like measures.
Yeah, right.
That we wouldn't as a state have to take. Just finding ways to like assess on things other than claims.
Right.
Score changes, but that wouldn't necessarily throw off like a primary care.
Right.
Don't know that parent.
Well, and I'm glad you brought that up because that was a conversation that at least Kathy and I have had recently is like, you know, in the mental health world, and I won't speak for social work or psychology, but being a mental health counselor, it's like where I was trained on a strength-based model, like what this person is their own expert, they're walking into the room. I'm not here to pathologize them or, you know, not really throwing a shade on the broader medical field, but you know, it was such a striking thing then to again work in broader healthcare field where it's like, well, no, what's your problems? Let's just focus on those rather than like, what are your strengths?
Right.
You know, like I think kind of what you're saying is like, well, yeah, your A1C levels are through the roof, but really all you want to do is be able to go ride your, you know, bike again. So,
Right.
so again, how to kind of, you know, capture a client family, I would say, but then also, you know, their voice and what is important to them, letting that kind of be one of the drivers of the healthcare.
Yeah, it's like, we have these Vermont strong, again, license plates. We don't have Vermont's not crushed as a license plate. We have like, we're doing good things. So
Right.
how do we help, we're thinking about performance for systems, for individuals, sort of micro and macro. We get into things that actually,
Right,
not academic things.
right.
Or just fiscal things, which are important.
So we would need to do that assessment on both medical and mental health. Like, it's promised?
Absolutely.
Okay, so it's adaptable? And that also combined with like also looking at the claims can also, you know.
Absolutely.
Yeah.
Yeah, I would love to, I mean, it's about that.
For sure.
Well, and I think again, sounds like, again, those testing codes would capture that, if like that, like, let's say the promise tool was administered, I mean, there's a procedure code that goes with that.
Here's a tricky thing, like, different guilds can build screen.
Sure.
assessment. It's like, three of us. Physicians can't. So, zero extra knowledge. So it's not exactly a code unless it's a sort of like, it's sort of a provider and special.
Right.
Which is also, I think, in a lack of.
Sure, yeah.
If my colleague walks into an exam room where I'm seeing a kid, does a PHQ to assess for depression, they can bill for that and make 2 months. I do the same thing, I can't. So there's no incentive for any mental health folks, see anyone, to do any of these progress monitoring tools. Those testing codes are just like formal testing. It's not doing, it's like measuring progress, which just continues to drive why nobody discharges patients in the mental health game. We don't know how the patients are doing because there's no incentive to ask standardized questions.
Right.
So.
That might be a,
Did you say, do you consider that screening? What were you
Screening
saying
and
about
progress
measure, progress monitoring? Okay.
I wonder again if that's a part of the assessment of the variety piece is kind of the hierarchy. It's just like, well, you have to be an MD or a DO to bill for this, and if it's not an MD or a DO, then everybody else is out. You could be a PhD, you could
You're
be
just
bachelor
doing it to be
level.
a nice guy,
Right,
and the system does not care if you're a nice guy.
but even though I would venture to guess that if we went into the research literature and looked at the evidence, like that would be a clinically indicated tool to administer at that point in life
Absolutely.
or that point of the care.
Totally.
And if it's like doing the right thing and making sure that, you know, those things are at least being assessed or discussed.
But the right thing doesn't pay the mortgage.
No, I know. That's
So
the
like
point.
until,
That's my
yeah, exactly,
point.
yeah, exactly, we're saying the same thing, so until we can make this part and parcel of doing not just good work.
Well, and
That's great. That's what, no, I agree completely. It has to, we gotta make it part of the system where we have control, where we have control over it, which for me is commercial,
Yeah.
fully insured plans, which is not self-insured.
Right.
But that's an interesting point too, because it was kind of discussed today, but it's something like Allison and I discussed the other day. What is the turnover around that? They're not paid well. They're doing such difficult work with people that are really experiencing some difficult times. And so how, again, you know, do we ensure that those folks, that there's not a level of turnover, that we have a robust workforce, that people feel like they're doing good work, and that people getting the care are feeling like we're getting good care. We're not just, you know.
You know, I used to, so before we moved to Vermont, one of my jobs at my previous hospital was like staffing adult kids. Like we had techs who were there for a long time. And they weren't like weirdos who were just statistically enjoying like restrictions. They were good people. And like they were young, they weren't, and they were both like there was a nice broadness and longevity. And so it's always been interesting to see that up here, it seems like the turnover is super high. We're just running through people. And this is a shitty, good, and disgusting. But stayed.
What do you think the difference is? Why do you think this?
I really don't know. Like cost of living is more tough, well, probably not. Actually. But like, you know, I don't think we're paying them that like tons of money. There's a union position, so there's some like stability in the job and protection to the job.
Annual raises, like
And
there's
like
stuff.
yeah. It's a step that we're contracted by, you have to ask and beg. So I don't know if it was those sort of like employment contextual things or just cultural or what, like people stay. So
Obviously, this will be anecdotal, but like, I take it people were somewhat satisfied.
you seem somewhat satisfied.
They didn't leave.
My guess is like, it's the fire hose of work up here.
Right.
Where maybe there are a few more endpoints to the system in Brooklyn, but no, I mean, overcrowd, like, wait, I shouldn't even be talking, I should just be listening.
People talk. Good job. So
Yeah,
I just don't know, like, there's a party that wants to go back. Are you still here?
Yeah.
You're not getting certified, you don't have funny initials after your name.
Yeah.
You don't, like, you've done the same job for like 7 years. Like, you could have been, you gone back to school, you could have worked someplace else, you could have become a cop, you could have done all these other things. Yeah, so.
But I think it goes back again, I think of the, you know, when I worked as a bachelor level case manager back in the
Yep.
day with, you know, people with their primary diagnosis was either schizophrenia or bipolar with psychotic features.
Yep.
But again, I was operating under my supervisor's license and I guess, but at the time I had no concept of billing
Yeah,
and, you know,
yeah.
again, what could be submitted and what was allowed versus like, what was the community mental health center where I was working? They were just eating it, you know, as far as the service that was being provided because it's like, well, we can't bill for it.
Yeah.
So. But I think that's something, again, we've kind of been discussing internally at DMH is just trying to think about, you know, how do we ensure, particularly people that are experiencing the most acute signs and symptoms, that their level of care isn't compromised.
You know, this may be in your like the longer report, but I wonder about in your recs about needs assessments and such, like having a specific call out to staff. Like,
Yeah.
is
Yeah.
staffing
Yeah.
turnover a performance measure?
Yeah.
And if it's not, let's do that.
Time to cycle again.
Go too fast.
Drop the mic, peace out.
Before you leave, I'll give you the CCBHC update, but I won't do it right now.
Okay. I'm super excited. So,
Recording's working because it's working.
Yeah, no, the drop off. Social support.
Thank you for taking notes.
Oh, absolutely.
See, especially the capture.
Yeah, no, and I'm purposely, glad they're showing. Because it's like not my expertise, so. How to correct it, which is great.
Yes.
So if other people, you know, like seeing like this development, I think that's helpful.
Yeah. Well,
It's
and
interesting.
talking to someone like him, that whole section of procedure codes. Well, and the psychologist is like, yeah, psychometric testing. Like, I remember taking the psychometric testing class in the counseling program, but. Venture to guess it's kind of similar in social work. You get like when you got your social work.
Well, that was helpful.
Yeah, I was just saying that, like, because he's a, like you said, he's a psychologist, and just having that lens on all of this, it's like, oh, right. Hello.
Good. You, baseball. Well, yeah, my nephew was, say Montpelier baseball player, and he's now off to college.
Yeah, there's a couple handouts there. Baseball. Through that a little
I think
bit.
it's soccer. So, mine was D&D, so.
Yeah, you know.
Hey, first one.
Master. Then he did start doing, he's only, they start doing, alternate springs. Yeah.
All right, so welcome everybody. Again, for those who don't know me, I'm Steve DeVoe. I'm the Director of Quality and Accountability at DMH. I co-facilitated this group with Ina Bacchus before she left her old position as the Director of Healthcare Reform. And then because there wasn't really enough time and, you know, there was a lot of moving parts and pieces to all this work, I just kind of maintained it. I did have some help from Sebastian, I'm going to butcher his last name.
Archwingo.
Thank you. From the Department of Financial Regulation. And then also Pat Jones, who you heard from today as well. Again, to just try to kind of keep moving this work forward. So today, really just wanted to present the two major recommendations that we have landed on, but I want to, you know, allow for enough time and discussion for you to ask questions, be critical, you know, make some, you know, concrete suggestions. Because as I said to the two previous groups, I want this to be actionable. So I really want it to be concrete. So that way from, you know, when we're looking at this in another 12 months, we've actually been able to make some progress because these are some big recommendations that are very sweeping. And it was also a little bit difficult at times throughout the last 2 years to really capture people's, where they were coming from when they were stepping into this space. Because there were some folks with lived experience, there was some, providers, there were some administrators. I'm thinking of Michael Hartman particularly, and he had a couple, being Michael, had some wonderful thoughts and ideas, and how, again, do we think of this from like a statewide level, but then also knowing that regionally, there's a lot of this work happening. And so again, not to interrupt that work, because there is a lot of integration, I think, happening on a local or a more regional level in the state. And that works for that particular region. So I think, again, there's different, parts and pieces and ways to think about this from different perspectives. So with all of that, I'm going to stop talking, but I will read the two recommendations, and then I'm going to just turn it over to all of you. So the first one was to conduct a formal needs assessment to assess variety and the use of performance measures across healthcare organizations, state government entities, and health insurance payers. A very small task. And the second one was to pilot integration models in different healthcare settings to study the impact on healthcare delivery funding and any improvement on established performance measures. And as I said to an earlier group, I was the one that initially drafted this language, and I would even change this one, because I would take out improvement, because I've learned in other areas of work that have come up in the last 12 months that there's groups that we have no data on. And so we can't even how do we know we're even going to make an improvement if we don't even have any baseline data on a particular group or a particular condition that somebody's experiencing, or an experience that a family is going through. So anyway, with all of that, questions, comments, concerns, anything is fair game.
You know what jumps out to me is data. Do you have, for number one, is the data available to do that? And I think of, you could go out and do a survey or collect your own data, but in terms of the existing data, we need features that has a lot of data, but there's some real big chunks that are missing.
Yeah.
Access to EMRs, not everyone submits data to the VHI, or even you have the Part 2 data that is a big black box.
Yeah.
So I guess I'm wondering if there's a recommendation for just looking at access and availability of data.
Mm-hmm. That had not been explicitly called out, but I think that it's worth calling out, because again, the VHI in my mind can be a potential one-stop shop. I've been on the data governance committee that is for the Part 2 data, that's involved Vermont Care Partners, it's involved the VA partners, there's been SSAs as well. And again, just looking at, the connectivity to the VHI from, let's say, just the VAs as a concrete example.
Yeah.
And then what are kind of those next steps? What data elements are going to be submitted to the VHI, the consent process, so there's a lot of moving stuff there, but I'm also very cognizant of the heavy lift of the monthly service report, which is DMH's go-to data source.
Yeah.
And it is fabulously outdated, to say the least. And it is a heavy lift, both on the state side and I would say the side. I hear from DA partners all the time around submitting their MSR data and
Yeah, so I guess I would recommend adding a recommendation around what data is out there and what's the quality of data and subject data. The only, the piloting integration models, I feel like there's a number of models that are already in place, and it's not like they're going away, but DAs, you've got the CCBHCs are coming on board, you've got F2HCs, it's another integration model that we looked at. It's not like they need to be, well, FQHCs I know at least do not need to be piloted. They've been in existence for 30, 40, 50 years. So I guess my question is like piloting integration models. sure what we're trying to accomplish through piloting. I can see like the degree, doing like an assessment of the degree of integration that we're achieving. Whether you're looking at different models that are in existence, but it's not for piloting at this point.
Right. So this wouldn't be like making up any integration models. Like this council, there's been a lot of different models that have been presented. So like, let's say the Ames model, that's care collaboration model out of the University of Washington. That model has been integrated in some respects, in some way, shapes, or form, but I don't know that there's ever been a formal study of that model within Vermont with a level of rigor that would need, that I would argue is needed to ensure that we're meeting that, really understanding, again, the funding piece and then, you know, the measurement. But I think, again, it's trying to really understand how best, you know, like, let's say what works down in southeastern Vermont, does
Right.
that work in northwestern Vermont?
Right.
Just based off of community partnerships that are available. You know, how does mental health sit at the table with broader healthcare in those areas?
I wonder if it's looking at like a scale of integration, so you kind of assess like how it, what does integration mean and how far along that integration spectrum is a community achieving?
Yeah, no, that's a great suggestion. And there is a tool that I'm aware of that actually does measure a level of integration. So at least like you can have some baseline, like you
Yeah.
scored 3 out of 5 on your level of integration.
And it could be both on the care delivery as well as the financial.
Right. And I guess when, you know, and again, having had a number of people sitting in this group and having this discussion, you know, there's people with data backgrounds, there's people with lived experience, there's, you know, people that are, you know, sitting in front of the Green Mountain Care Board. I mean, a lot of different folks and how best to kind of integrate it all together, and have it still be very person and family centered.
The only thing I'll say is like, you know, what level of analysis doesn't really indicate what level of analysis you plan to do. Or like the cross analyzing of health disparities across the state and risk adjustments.
Yeah.
I mean, that would be one recommendation I would add in here.
You say that one more time.
Cross analyzing with health disparities across the state and applying risk adjustments for health outcomes. Because the data itself is not necessarily as valuable if you're not also looking at the population level data as well.
Right, I guess a question, because we're talking about performance measures, well, other things, but is the framework that's being used, I mean, I'm thinking like, are we talking about, you know, result-based accountability, like impact, or we, you know, I don't want to go too far into the past, but I remember, you know, many years ago, there was like many funding for regional partnerships, which again were kind of, you know, some were really incredibly successful and others, you know, it was challenging because, you know, it was I think it was 25,000 per AHS district. It was not a whole lot of money. And in Casey, I'm not sure if that's really money. I'm not sure where they're. But I know in our area, we had the Alliance for Building Community, and Diana Waller did an amazing job working as the leader of that. And she worked really closely, actually, with Con Hogan now all the time. It was RBA was looking at, was really using that with that model with fidelity to look at how well are we actually having an impact on people's lives, population, but also programmatic. And how does each organization contribute to those population-based, those changes that are impacting our, you know, again, specific populations and so on, but sort of having that framework is helpful, and the data definitions and the EMR, the health information exchanges that will support making sure that we're getting, you know, not just apples, you know, like apples, but like Macintoshes, or you know, whatever, you know.
Being from Washington State, I appreciate that.
Yeah, I want the right, you know, so, and I think, and that is, to some degree, that's a culture shift, but it's actually kind of going back in time, because there was a real effort around it. It was actually kind of neat. I was very involved with that. You know, in the southeast, and we kind of lost it. Which was kind of sad, you know, because it was really, and I know BDH and AHS kind of had adopted, it, did a lot of work with Mark Friedman, you know, I think, so I can't remember who, but he was brought in to really help create and support that effort. So I do think, looking at the framework, maybe, you know, so in terms of performance measures, that's really important, but, I don't know what else. Oh, and then integration, yeah, there are, you know, sort of, there's, it sounds like you've got a lot of, there's a lot of literature around levels of integration, and what does it mean? You know, one of the things we're doing, and then I'll stop talking about it, there in Brattleboro, there's, we have this program, it's a collaboration between the Retreat, DMH, Brattleboro Memorial Hospital, HCRS, and Groundworks, which is our, homeless shelter and drop-in center. It's called HealthWorks, and we have formed an LLC, and we basically took all of that money and we put it together, and we're collaboratively staffing, you know, we have a steering committee, we have board of managers, on board managers, so, you know, we kind of oversee, and we basically take that money and say, so we need peer, well, we're doing the peer support. We need substance use, so, you know, so the retreat might be doing that. We need a clinical APR and prescriber, because it's using an ACT sort of community treatment model to support folks that are homeless with mental health and current, you know, substance issues. Who may also have health-related issues. It really is a great model. So we're just pooling that money, bringing it together, and it's complicated. Because our culture and, you know, with all due respect to all organizations, our respective cultures are different. And so I'm not going to get into the complexities, but it's working and it's getting there. But it's kind of like there's a lot of what do we call wrong. Around like but it's good. And I know Patrick Flood in the Northeast, you know, I think many, many years ago, he was thinking of like a global community, but he was definitely broadly as, anyway.
Can I ask you a question? Is that your accountable community for health?
No, we just did it
Is
on
it
our
your
own.
separate thing?
You know, we met with DMH and Retreat, doing peer review. You know, we had Kramer and our attorneys to make sure that we got, you know, so we could actually speak both systemically, but also in terms of shared clients. And we did that for like 4 years, 5 years. It was really, really great. And one thing led to the other, and we say, you know what, this is what we need. So let's figure out a way to get the money. And
That's amazing.
it took us years, but we finally we're able to fund it, like 1.2, 1.3 million, various funds to create this sort of community treatment thing. We thought we got to do LLC. You know, and we work with all our attorneys to figure out how to create those structures and all that. But it wasn't connected to the AC, you know, how it was, yeah. It was, go ahead.
Oh, sorry,
Yeah.
it just kind of on a really focused level on this, you know, as you know, we do work. And I was just thinking under the financial recommend, where it says, you know, assessment could include this financial. I would recommend including that to specify employment. Only because, I just point that out in our recommendations that there's a very big employment gap between Vermonters with disabilities. And I think that if, you know, getting to the employment, just, you know, kind of linking it back to the parity, we know that employment parity is there for people with mental health disorders. And if we can separate that out, I think that will, that ties in so much to the other health outcomes, that it might be a way to get, you know, financial is so big, that might be a way to get a little more into that financial piece, with, you know, a known existing that could also help other health outcomes. So
I would be remiss if I didn't give you the chance because you did submit feedback. Much appreciated. So I don't know that everybody knows who you are and the work you do, but you have like a 1 minute elevator speech.
Oh my gosh,
Not to put
thank
you on
you
the
so much.
spot.
I don't want to take over because there's so much more than just that. But we were funded by the U.S. Department of Labor through the Vermont. Just have an early return to work program in Vermont based on a successful program in Washington State to prevent work disability. And, you know, the feds are coming at it. Vermont has one of the highest rates of working age people on social security disability. And the most common reason for long-term work disability is mental health diagnosis. And so we're up there as, you know, one of the top states with this issue. And so the feds come at it from, obviously they care about the solvency of the SSDI system, but we're really coming at it how work affects health and how health affects work outcomes. And so, you know, there's a lot of good evidence that appropriate work mitigates a lot of the other, you know, kind of intuitively, like access to housing. So we just were advocating for employment, you know, just having someone who's aware of the links between mental health and employment and including employment in the outcomes as sort of a little bit more, just a little bit more of a specific.
And to add to that, one of the suggestions I was also going to make was balancing measures. So like anytime you implement something new or a new program or pilot something, it's good to also have, well, if we do this, do we think it's going to affect this as well? And I think employment data is one piece of that. And I think the other piece of that is looking at just standard level of care across the state. And if you see any change in access to new providers coming, you know, new providers moving to Vermont because of the changes that we're doing, are you seeing lower levels of burnout? You know, so kind of coming back to those secondary and tertiary outcomes of if we create a more integrated model, are we also creating a more integrated model for people to stay at work?
And one thing I'll add, and we put this in, so Minnesota is another free team state, has the same funding we have, and they're working with Mayo Clinic. So Mayo Clinic did introduce a really just very tactical employment question into their social determinants of health survey that is one question that gives a lot of data on so we have permission to use that, and they've shared that with us. So as you're doing this, you know, if the employment is integrated, just feel free to reach out to us for kind of how to look at that. Because I know that they worked out, you know, I mean, it was years. It took them to come up with this very, very tactical electronic medical record implementation. So it could save a lot of time on.
It's interesting, at least in the CCBHC realm, one of the new certification criteria that just came out in March of 2023, one of the clinic-specific measures that's required for reporting is social determinant of health screening. So that's something that we've been looking at as the state, is how, you know, what are those different tools, but then how do we not add that burden onto the providers if there's another tool? So leveraging, like, for example, the CANS and the ANSA, because, and that's something we might have to fight with SAMHSA of like, can that count? Because it does assess those different level or the different areas of somebody's life or a family's life. But again, not to put that burden on obviously the person or family receiving care and the provider themselves, like, here, just go ahead and ask another 15 questions, 100 questions, that'll fit into your workflow, right?
One of the barriers though to that is that I had to work on getting new screenings into EMRs, and some of them already have like standard screening tools built in for their add-ons, so that costs money. And so oftentimes, like, well, we're not sure if the providers or, you know, the care coordinators are going to do the screening anyway, so why would we devote any money to making it available? So maybe one of the suggestions I would say, like, to integrated funding is identifying where there is some really clear of the
agencies and organizations that are interested in expanding and integrating social determinants of health screening, could there be money allotted to helping either have the add-on added or have some money that helps pay for somebody to do that?
I think for us as a department, we are definitely, and we're working with, BCP and our DA partners around assessing administrative burden.
Oh, my God, yes.
And I'm raising the car, but it's something that comes up time and time again. And then when we're thinking about workforce retention,
Exactly.
people getting burned out because it's like, if DMH makes us ask another 5 questions, I'm out of here.
Well, with the
Just
CCDAC
one more click.
I mean, with CCDAC, we've actually built into the budget staff who are reaching out to clients or folks who are needing, seeking services around the give road, which anybody that knows. It's like, it's massive. I mean, yes, it's useful, it's information, whatever, but it's a lot. There's incentive. I know there's self-sufficiency measures, then there's whether it's valid and reliable, but it's pre-existing. But anyway.
Just want to thank you all for your participation.
Thank you.
Please take the handouts over there.
And one of those from the table.
Yes. If you didn't grab them over there, I'd made another pile.
Oh, great, yeah.
Yeah, I don't know what like 10-second speech I
Yes,
could give
we're
walking off.
redoing our primary care, mental health and substance use list at DFR. This is the difference between primary and specialty. So come tell us what's missing before we finalize it again.
Thank you.
Awesome, thank you so much. Yes.
Reach us.
I can give you my card.
Yeah, perfect. Do you know where?
I do not.
Thanks, Steve.
Sorry.
Very far.
Thank you.
We have
You. Yeah, like.
Sam. Here, I can very much talk.
I work at Washington County. Oh, you're what?
Oh, thank you.
Both important.
See what comes back.
Am I supposed to?
Oh,
I'm in a group of one.
No, wonderful. You're the second group of 1,
I am.
but not like second place,
It's
so.
funny.
For whatever.
Worked out.
Yeah, so there's a few different
Yeah.
handouts there. The first one that's in your hand is the initial recommendations that this work group made to the interim report. The next 2 are formal feedback that we received. One is from the Vermont Retain Initiative.
Is this global to all the groups, the one from this group?
Yes, I
Visually,
think
it
so.
looks similar,
There.
So I already have one of those.
And then the second one was from Recovery Vermont, in
Yeah.
Vanpar. Will Everly
Yeah.
had submitted that. And then the last one is from the Department of Financial Regulation, which, since you are a group of 1, we can talk a little bit more in detail about that. And Anna Van Fleet is from
Nice to meet you.
DFR, and I won't butcher the initiative, but it's very exciting and very relevant to all of this work, so.
Cool.
So I'm Steve DeVoe. I'm the Director of Quality and Accountability at the
Beautiful.
Department of Mental Health. And tell me your name again, or tell us your
It's
name.
okay, it's Leslie Nelson, and currently I'm the coordinator of peer support and the coordinator of the collaborative network approach for Howard Center.
Do you know Cheryl Wilcox?
I do not.
I will let her introduce herself.
Hi, Cheryl Wilcox, the Department of Mental Health and the Director of Mental Health Operations. In this group to take notes to make sure.
Okay.
Arguably the most important person in this every room. And then I'll let Anna
Anna
introduce herself.
Van Fleet, Department of Financial Regulation, and I'm here to invite participation in a stakeholder process that's starting soon.
Okay,
And this is like your takeaway. It's like,
okay,
if you want to join in, everything you need is here.
beautiful.
So I'll just scroll back to the top real fast. And there was some initial recommendations that were made. Again, this work's been going on for a couple of years now.
Yeah.
This work group particularly, the makeup of it has kind of evolved over time. I was co-facilitating this with Ina Bacchus, who was the former director of healthcare reform for the state. But she moved on. Peter Welch became senator. Now she's doing, I think, healthcare related stuff for him, which is awesome. But yeah, this group has been made up of a lot of different folks over time. You know, administrators, policymakers, direct care providers, people with lived experience, family members of those with lived experience. So it's been a really interesting kind of, I would say for me, journey to hear different perspectives on things. But I'll just read off the 2 recommendations and then
Sure.
I'm gonna let you have at it. So, and especially being from the peer specialist and support world, would love to hear what you have to say about these. So the first one was to conduct a formal needs assessment to assess variety and the use of performance measures across healthcare organizations, state government entities, and health insurance providers. So really just trying to think about it from a statewide perspective of, you know, what are the variety and disparity issues that we're, you know, seeing amongst different subpopulations, but then also, you know, work at the Howard Center. So, you know, thinking about a performance measure, particularly, let's say, for our community mental health centers in the state, not adding more burden on as far as measurement goes, you know, but really thinking creatively around, you know, if we were assessing some level of performance on a measure, you know, is that a measure that aligns with the physical healthcare world in addition to the mental? But the performance measures definitely has taken a, it's been a lot of different things. Hey, Sandy, how are you? Welcome. I was just reading this first, this top recommendation, which again, I'll just repeat real fast. It's to conduct a formal needs assessment to assess variety and the use of performance measures across healthcare organizations, state government entities, and health insurance payers. And then the second recommendation that we had made was to pilot, you know, I'll be a little bit more explicit here, but to pilot one of the integration models that we have studied as a council in different healthcare settings to study the impact on healthcare delivery funding and any improvement on established performance measures. So, so Sandy, as I was just mentioning, I just wanted to give both of you the time. We have a few, Cheryl Wilcox is in the room, and then Anna Van Fleet from the Department of Financial Regulation is also here. And then I'll let you reintroduce yourself to, if you want to.
Hi, I'm Leslie Nelson. I'm the coordinator of peer support and coordinator of collaborative network approach at Howard Center.
Leslie, and Sandy, I'll let you introduce yourself if you'd like.
Thank you. I'm Sandy Yando. I'm the executive director of the Vermont Federation of Families for Children's Mental Health, and we've been providing peer support for 33 years.
Yay.
So yeah, my like personal or selfish thought about all of this is I wanted to let you have time to ask questions, express concerns. You know, as I said, the other group, like just shoot holes in this because again, we want to make sure that the language is reflective of the work that needs to happen. And as I've said to the other groups as well, I'm really looking to have this be concrete, actionable recommendations because I want to, you know, again, and I say this selfishly, but I also say this, you know, as a representative of DMH, you know, in 12 months, I want to be able to see personally, like how much progress have we made? And if things aren't concrete and actionable and time limited, then I just personally know how those things kind of go off the rails and then no progress has been made and then 12 months have gone by and it's like, holy cow, what have I been doing for 12 months? So anyway, but I'd like to just turn it over to the both of you again to ask any questions, comments, anything you'd like to share.
Well,
Please go ahead. No, please, you go.
It's just been weighing heavily on me lately that as we look at peer certification, and I look at it very selfishly from our lens at the Federation, where we've been around forever and a day, to get the basic cost, if we wanted to even think about having one of our peer specialists get certification under our National Federation of Families chapter organization that of which we've been a chapter, there's a minimum cost of $20,000. And that is a huge investment for a family-run organization that with that investment, for them to even be able to apply for certification, they have to have worked 500 hours, had 88 hours of training, had 20 hours of supervision. And that is in it if we had work. And as we know, part of what we've been talking about under mental health integration has been creating the workforce development piece around peers. So, and so that weighs heavily on me. And as I think about the funding piece and going forward, and that's in children's mental health, that's just through the children's mental health lens, not to talk about the fact that we support families. So, and an age continuum from 0 to 22 by mission, but what we know is at least 0 to 26 plus the family unit. So that is a huge cost investment. And that is only if we're talking about through the National Federation of Families, who put a huge investment into creating a national certification in children's mental health a decade ago. And having been part of that and have watched how slowly we have crept forward, I like actionable. That happens in the next 12 months. So I might just.
Can I ask just a couple clarifying questions? So for somebody to get that certification, it's $20,000 per individual, is that correct?
I would look at that by the time we made sure that their training was in all those core competencies and,
Gotcha.
Offered it so that they had those 88 hours so their application would be accepted, plus the fact that 500 hours of work, that is over a 5-year span, but
Right.
and how is that work even funded when you look at, an entity that's been around a long time, and then the supervision, what does that look like? We see peer support positionings opening in different venues, and we haven't yet quite arrived at a one size fits all. And I was part of bringing recovery coaching to Vermont, so I know what we envisioned again a decade ago when we worked with CCAR to bring it to Vermont, and it's evolved greatly over that decade with the Recovery Coach Academy and then the certification on the substance abuse side. So it's a big topic and has been a big topic for a long time. So.
And then my other question was, does the National Federation, and I think you said this, they're the ones that kind of came up with the whole certification process, and correct me if I'm wrong, are they the ones that grant the certification?
They have a commission. It is a national certification. It was, a big deal process, the psychometrics involved in creating a national certification and the millions of dollars that it went into creating a commission. And so it was a very, big deal thing. And then each state, we've learned that each state can create their own certification, for us, because we are a chapter under. It just made more sense because we like a lot of, straight line approaches, so if you were a chapter under the Federation, it was felt, of course, we would look to the national for that because that infrastructure was already there. And why recreate the wheel? But and we have people who have 15 years plus of providing peer support, maybe through an individual lens. And we have, providers who provide peer support through very much that independent lens. So That's not the idea behind what we would do if we were getting someone certified through the federation. It would be, everybody would have the same training on boundaries and ethics. Everybody would have, and here are the core competencies. The federation has already invested in all of that. And I know, we talked with the legislature about that when we were looking at adult certification and the legislation behind that. And we are a very different population than the adults. And we're working with a multi-generational population because we're working with parents, grandparents, adolescents, young children, and not working directly with the children as in the adult substance abuse world, where you are working with the actual peer recovery coaches or working with the one line individual and then broaden with family, because over the years we've built in recovery support services to families. So I think the difference, I have a lot of thoughts and theories. Nobody's asked me, but if anybody ever wants to, please feel free to call me because I'd love to talk about it. The difference, the amazing progress we've made on the substance abuse side with creating recovery coaches through the Recovery Coach Academy, having the Recovery Network, places for people to build their skills while working, in those communities and continuing to receive support. And now what, VAMHAR has, been able to push with the certification on that side. We don't have that same infrastructure in mental health,
Yeah,
and we need them.
Will did, sorry to interrupt you. Will did submit formal feedback on that topic, and I know he's spoken about that previously in previous council meetings. And at least for me personally, that point is very well taken, and it's highlighted kind of, again, the disparity between recovery coaches and peer specialists in the state. It's something that DMH is obviously aware of. But again, I guess I didn't appreciate that level of disparity. It's like, wow, recovery coaches and just the formal recognition is so much farther along. So.
Yeah, I would add to that, I don't have nearly the experience and depth of knowledge that you do, Sandy, so I really appreciated hearing you. So glad we ended up in this thing together. But just as an easy example, I would offer the University of Vermont Medical Center that, clearly has a contract with Turning Point, but they don't have any sort of contract for mental health peer support. And that's been for years, and I've not been able to get anybody to offer a rationale for that disparity. And when I do try to assert the topic, then it's easy for me to become the bad guy, or the difficult one. But it makes no sense to me, and like I said, the recovery coaches, I'm all for them, it's not about one or the other, right? But, what is the rationale for recovery coaches being able to be in the units, the psychiatric units, but not mental health peer specialists? And who can answer for that? I would offer that with mental health peer specialists, there's also a national certification through the National Association of Peer Supporters. So there is a national certification available to anyone. Vermont, as we know, is one of 2 states in the country that has not thus far had a peer specialist certification. One of 2 states in the country. And again, I haven't been able to get a rationale for why that lag has existed, but I think some of these things might be tied together. And I would just maybe offer that maybe it's worth looking into, does this correlate with outcomes and how people are doing or not doing? We know that the research shows exposure to peer support or having peer support reduces hospitalization days, reduces costs across the board. And that's important, of course, but also we see better outcomes and quality of life measurements, decreased disability. That's my spiel on that.
Yeah. Can I repeat it back just because I think it's an interest. As a researcher, I love that type of question. So again, looking at kind of, if we were doing 2 comparison groups almost, when there's a peer specialist involved or a recovery coach, let's say, you know, looking at those health outcomes, looking at those quality of life measures versus when they are not.
Are you asking for where the data is?
No, I'm just asking that, like, that's kind of what you're suggesting. Yeah.
Yeah.
Because that, I think, again, my wife's in evidence-based medicine, so I appreciate it. I'm like, well, what does the research literature say? What does the evidence say?
Yeah, I'd be
so I
happy
think
to
that's-
send you anything that you would want. I mean, because it's not really new research.
Right,
It's not really
right.
new information,
Yeah,
which
no.
again makes it all the more stunning.
Totally. And the fact that Vermont, particularly obviously in the peer specialist world, we're grossly behind.
And I should, for transparency, add that I come from New York City, where I was on the Manhattan team of the parachute program. So that also was a very innovative, that was a CMS $17.5 million project, which basically one of the parts that was significant was it was infusing peer specialists into the direct delivery of mental health services. I think that project created like 84 peer specialist positions. It also created 4 peer staff respites in New York City. So there's a lot of data that came out of that. Some data sort of has disappeared, but there is a little bit of research, a little bit of data that came out and reduced hospitalizations, reduced costs, and so on and so forth per individual. Or comparing the number of days inpatient the 12 months previous and then the 12 month, that kind of thing. There's some comparison available. But oddly enough, a lot of the research seems to have.
It's hard to find, or.
I mean, there's a white paper.
Yeah, right.
And there's a lot of stuff out there because we also segued with peer specialists that were providing services that were Medicaid billable versus those who weren't, because it all started to develop during that family voice movement, where a lot of family-run organizations weren't the least bit interested in Medicaid billable, that you lost something, that you were medicalizing the whole role of peer, and so, now that, I think the exciting thing, this is a personal aside, that at 71, I think what's really exciting is the work Vermont is doing around is talking about inherent bias and stigma and biases of many kind and structural racism and all of that is kind of going to help dismantle some of this. And when you talk about, where does it come from on the hospital level? Because we wondered that too and it was probably not a good time to try to do that when I jumped into the Federation 3 years ago. COVID arrived 3 weeks later and no, it was not my fault. What I was particularly concerned about were children in the emergency department. So if we had people ready and willing that would, sit with a family or serve a family or support a family after hours or whatever, if you could just tell them that we existed, and what was it? And we got a very clear answer from the hospital, and it was, the concern about liability. Who the heck are you and how do we know what you will tell them about our institution? We're not going to tell you jack about the institution. We're probably going to blame, if we were going to badmouth anybody, it would be, that we are not a state that, are built to scale to meet all the need that exists. So, and that's just the reality of this state and, the situation that we find ourselves in. So, but to deny families, even basic information that there is an entity available that would love to talk to you in the wee hours in the morning when you can't sleep because your child is there. Basic.
Yeah. Well, I want to say just a couple things real fast. So, we, the state, particularly DMH, in partnership with the health department, have a CCBHC planning grant. So, Certified Community Behavioral Health Clinic planning grant. And one of the tenets that's a requirement to become a CCBHC is that there are peer support specialists on staff. and that those services are provided not only to the individuals, but to the families. So I think, again, that's something that's really exciting for me personally, to be able to leverage that, because this keeps coming up, like, one of the teams that I supervise and support is our state program standing committees, which is made up of primarily of individuals with lived experience and family members of those. And so hear a lot about the need for peer specialist support and the lack. And it's just, I feel bad because it's just like this broken record, which I know that's what it is. But again, I wonder, for the billing component or the procedural code component, making sure that we've added that into that list as well, to think about, how do these services get paid for? Because again, it's like, people aren't just gonna be giving time out of the goodness of their heart,
Right.
but
Well, Georgia was the first state to to be reimbursed by Medicaid for peer support, and that was in 1999.
So maybe can I? So I'm from financial regulation and do insurance, so we regulate the fully insured market, which is not self-insured plans, just Vermont plans. We are tasked with keeping the list of what counts as a primary care, mental health, or substance use disorder code. So we'll be sending this out after the meeting today, but I'm sort of fishing for stakeholders here. We're just starting our process of looking at the current list of what's considered primary care and seeing if it's sufficient or needs revision. And so I've just put together, what is the list, what are the criteria, and what's the timeline, and how to get involved. So we would be happy to have your perspective if it's of value to you.
And yeah, Sandy, we can send that out, just so you have that information. I believe it'll probably be sent
Thank
out
you.
with
After,
all the meeting materials, so.
Great.
And Sandy, I think you have my contact information, so if you wanted to get in touch with Anna, you can contact me and I can facilitate that, so. I think this is it, so we're gonna join the larger meeting. Sandy, you can just click back on the main meeting link, to get back into the bigger group, and thanks for being here today.
Thank you, Sandy.
Take care.
Nice meeting you.